Are we mental health professionals? It's a question that might make some of you uncomfortable. And honestly, that discomfort is exactly why I want to ask it. Because the answer isn't as simple as yes or no. And if we're being honest with ourselves, if we're really being honest, most of us are already influencing our patients' mental health every single session. We're just not talking about it. So today, that changes. Hey there, I'm Jamie Johnston, and you're stepping into a new era of thriving as a massage therapist. We're embracing who you are, pursuing what you love, and confidently shaping your practice. We'll challenge industry norms, spark change, and discuss what truly matters. Things like mental health, evidence-based practice, and some topics we've long avoided. Let's create better outcomes for our patients and happier, more fulfilling practices together. Welcome to the New Generation Massage Therapist Podcast. Welcome back. I'm Jamie Johnston, and today we're kicking off a three-part series that I've been wanting to do for a while. It's called, Are We Mental Health Professionals? And I want to be clear right from the start. The answer is no. We're massage therapists. We don't diagnose psychiatric conditions. We don't provide psychotherapy. And that's not what this series is about. But here's what I've come to believe after years of practice, years of responding to calls as a firefighter, and years of thinking deeply about what actually happens in our treatment rooms. We wield a profound influence over our patient's psychological state every single session. And most of us were never taught that, which means most of us aren't being intentional about it. That's what this series is going to fix. Over these 3 episodes, we're going to look at exactly how our daily practices, the words we use, the way we show up, the environment we create, are already shaping our patient's mental well-being. And we're going to talk about how to use that influence responsibly to create genuinely better outcomes. Today, in part 1, we're starting with the foundation, the hidden half of every treatment that nobody taught us about in school. So let's get into it. I want to start with something that I think a lot of us have assumed without ever really examining it. The idea that if we just fix the physical problem, if we treat the tissue, address the restriction, work the muscle, the rest will sort itself out. That the anxiety will ease, the depression will lift. The patient will walk out feeling not just physically better, but mentally better too. And it sounds reasonable. It makes intuitive sense, and it's worth examining carefully. Let's talk about what the research actually says, because I think most of us have been underselling ourselves here. And I also want to be honest with you about where the science is still evolving, because that's how we do things on this podcast. There's genuine debate in the research literature right now. Some systematic reviews have questioned the magnitude of massage therapy's effects on anxiety and depression, suggesting the effects may not be as large as earlier studies indicated. And that's worth knowing. We should always follow the evidence where it leads, even if it's inconvenient. But here's what's well supported. A single session of massage therapy has been shown to significantly reduce state anxiety, that momentary experience of apprehension, tension, and worry. And across a series of treatments, the research consistently points to meaningful reductions in both trait anxiety and depression in adult recipients. And these effects, even accounting for the debate around their magnitude, are considered among the most well-established findings in our entire research literature. In fact, some researchers are now arguing that it's time to formally recognize affective massage therapy as its own subfield, specifically focused on understanding and optimizing how massage influences mood, emotion, and psychological well-being. Because even with the ongoing debate, the signal in the research is strong enough to take it seriously. But here's where it gets really interesting, and this is the part I want you to sit with. When researchers look at why massage produces these effects, one of the leading theories points directly to the social and relational components of what we do. The therapeutic relationship, the human contact, the experience of being genuinely cared for by another person. Which means the physical treatment and the psychological influence aren't two separate things happening in your room. They're deeply intertwined. And if we're showing up distracted, rushed, or emotionally disengaged, we may be undermining the very mechanism that makes what we do so effective. So the assumption that we're just manual therapists, that our job begins and ends with the tissue in front of us, that assumption isn't just incomplete. It's leaving our patients without something they genuinely need. Now, I'm not saying we need to become psychologists. I'm saying we need to understand that physical only care isn't really a thing. Every interaction we have with a patient has a psychological dimension, whether we acknowledge it or not. And here's something else I want you to sit with. Every interaction you have with a patient, every word you say, every pause before you speak, the way you make eye contact when they walk in the door, the tone of your voice when you ask how they've been, every single one of these things is either mitigating your patient's distress or inadvertently making it worse. There's no neutral. You're always doing one or the other. Your clinic environment sends signals. The way you introduce yourself sends signals. Whether you seem rushed or genuinely present, that sends signals too. And your patient's nervous system is reading every one of them constantly, deciding whether this is a safe place to be. So, this is what I mean when I say we wield a profound psychological influence, not because we're trained therapists, but because we're human beings working in close physical contact with vulnerable people. And that contact, the relationship, carries weight. The question is whether we're being intentional about it. So let's talk about where that influence actually starts. It starts before your hands are even on the patient. It starts the moment you walk into the room. Research on patient therapist interactions tells us that a strong, empathetic therapeutic relationship, what researchers call the therapeutic alliance, doesn't just make patients feel better about their experience, it actively lowers their anxiety. It's a prerequisite for recovery. So think about what that means practically. A patient who doesn't trust you, who feels dismissed or rushed or judged, is a patient whose nervous system is still on alert. And a nervous system on alert is not a nervous system that's ready to respond to treatment. So the therapeutic alliance isn't a nice to have, it's clinical. Now, one of the most powerful tools for building that alliance is something that most of us actually have a natural instinct for, but often override in clinical practice. And that's active listening. Active listening isn't just staying quiet when someone talks. It's giving patients the space to share their story uninterrupted. It's resisting the urge to jump to solutions. It's validating their emotional experience before you start problem solving. And I know that can feel uncomfortable for us because we're trained to move toward action. We do assessments, we develop treatment plans, we get to work. But sometimes, especially early in a session or when a patient is opening up about something that's clearly more than just a physical complaint, the most clinical thing you can do is just slow down and just listen. Because when patients feel truly heard, something shifts. Their anxiety lowers, their defensiveness drops, and they become far more receptive to everything else you're about to do. Then there's the nonverbal piece. Your eye contact, your body orientation, whether you're leaning slightly forward to the patient or angled away from them, whether you look distracted or genuinely present. All of it is communicating something. Research shows that maintaining eye contact, keeping an open body posture, and bringing a warm demeanor to your interactions actively lowers your patient's anticipatory anxiety before you've said a word. And the flip side of that is worth naming too. When we appear rushed, when we're checking notes while someone's talking, when we're clinically efficient but emotionally cold, that creates what researchers call a relational rupture. It disempowers the patient. It can actually increase their feelings of distress, and it worsens clinical outcomes. So the next time you walk into a treatment room, ask yourself, what is my presence communicating right now? Now, I want to introduce you to a concept that I think is one of the most useful clinical assessment tools we have, and it has nothing to do with the tissue. It's the concept of mindset. Specifically, the difference between a fixed mindset and a growth mindset. And understanding which one is sitting in your treatment room changes everything about how you approach the session. A patient with a fixed mindset believes their body is permanently broken. They believe their pain is static, that this is just how it is. This is how it's always going to be. And nothing they do is really going to change that. Effort feels futile to them. Hope feels like something other people get to have. A patient with a growth mindset believes something different. They believe that with the right guidance, with consistent effort, with good support, things can get better. They're engaged in the process. They've bought in. Now, here's the thing. We can't apply a one-size-fits-all approach to these two patients, because if we do, we're not actually treating the person. We're just applying a protocol. If you don't recognize and adapt to your patient's mindset, your physical treatments will face real psychological barriers. A fixed mindset patient who believes nothing will help isn't going to follow through on the home care you give. They're not going to stay engaged across a treatment plan. They may not even relax enough on the table to respond to what you're doing. So part of our assessment, part of what we need to be doing in that first session, and frankly in every session, is getting a read on where our patient sits psychologically, not diagnostically, not therapeutically in the mental health sense, but clinically as a massage therapist who understands that mindset dictates behavior. So what do we do with a patient who's stuck in a fixed mindset? These folks often present with low motivation and high anxiety. They may have been everywhere before they got to you. Multiple practitioners, multiple approaches, and nothing has stuck or nothing's worked. And that history has calcified into a belief that nothing ever will. The worst thing we can do with these people is front load the big picture. Don't lead with long-term treatment plans. Don't talk about where they could be in 6 months. Because from inside a fixed mindset, 6 months feels impossibly far away. And the gap between where they are and where they could be just reinforces their sense of hopelessness. Instead, restructure the goal entirely. Give them something small, something achievable within the session itself. Because here's what happens when a fixed mindset patient experiences a small, tangible win in a single session. Even something modest, even something that might feel minor to you, it proves something to their nervous system. It proves that their body is capable of change. And that proof, that lived experience of something being different, starts to quietly chip away at the belief that nothing ever will be. You're literally building their self-efficacy in real time. And self-efficacy, the belief that your own actions can make a difference, is one of the most powerful predictors of recovery we have. We can also use our language intentionally here. Conversational reframing, gently helping patients identify and challenge the unhelpful thought patterns they're voicing, doesn't require a psychology degree. It just requires presence and attention. When someone says, "This never gets better," you don't have to challenge that directly or lecture them, but you can say, "That makes sense given what you've been through. Let's just focus on what's happening today and see what we notice." That's a reframe. That's you quietly shifting the frame without making the patient feel argued with, or dismissed. Now let's flip to the other end of the spectrum, the growth mindset patient. You might be thinking that these patients are easy. They're motivated. They're bought in. They want to get better. And that's true, but they come with their own clinical challenge. Growth mindset patients often push themselves too hard. They hear, "Do your exercises," and they do them twice a day instead of once, or just more than they should. They feel better after a session and go back to full activity too soon. They're so motivated to get better that they outpace what their body can actually handle right now. And when they inevitably overdo it and have a setback, and they will, if we don't manage this well, the psychological crash can be significant. The frustration, the feeling of going backwards, the loss of trust in the process. All of that is real, and all of it makes our job harder going forward. So with growth mindset people, our role isn't motivator. They don't need you for that. Our role is regulator. We need to be the voice that says, I love your commitment to this, but let's make sure we're pacing it in a way that actually protects your progress. Set clear boundaries around activity. Explain the explain the timeline of tissue healing and why respecting it actually gets them to their goal faster, not slower. Help them channel their motivation strategically rather than letting it work against them. Because protecting a growth mindset patient from their own enthusiasm isn't holding them back, it's protecting their long-term mental health from the burnout and discouragement that comes from preventable setbacks. So let's pull this together. Are we mental health professionals? No. But we are, in every session, psychological influencers, whether we want to be or not. The therapeutic alliance we build, the way we listen, the nonverbal signals we send, the mindset we assess and adapt to, all of it is already shaping our patient's psychological state. The only question is whether we're doing it intentionally. And that intentionality, that's what creates better outcomes, not just physical outcomes. Real, whole person outcomes. In part 2 of this series, we're going to get into something that I think is going to make a lot of you uncomfortable. And that's exactly why it needs to be said. We're going to talk about the way our words can actively harm our patients, about the language that we're taught to use that is quietly working against the people we're trying to help. It's called the nocebo effect. And if you've ever heard of it, you'll want to tune in. Because chances are you've experienced it from both sides of the table. But that's next week. I'll see you then.